Welcome back, everybody. Really excited to be here today. I'm going to just go ahead and quickly introduce myself and the panel. So my name's Kristen Oliver. I'm a pediatrician and preventive medicine physician at Mount Sinai in New York City. I've been fortunate enough to be working with the Cure19 group for the last couple of months around vaccine confidence, specifically for the COVID-19 vaccine among healthcare workers. And through that work, we've been collaborating with a great number of people who have joined us today to talk about this issue. I think it sounds like some earlier discussion today made people even more concerned about what's going on with our vaccine rollout. I tend to be a vaccine glass half full person. And so I think it's, let's focus a little bit on the positive. We've got over 19 million people vaccinated in the U.S. so far, and we've only been doing this since December 20th, right? And so we're on our way. There are a number of challenges that we're going to have to face, obviously some big logistical challenges in terms of availability and rollout and getting the vaccine to the people who need it and want it. And then the other big challenge is that issue around who wants it. And there are definitely a lot of concerns around vaccine confidence in the general population and also specific to healthcare workers as well. And we have a good group of people here who can talk about that. They've done that work previously in the past and are working on it now as well, in particular for COVID vaccine. And so we have some good strategies that we can draw on. I think we're probably going to need some new strategies as well, and we're going to dive into that now. So I'd like to go ahead and introduce our panelists. Also remind everybody, please go ahead and enter your questions into the chat box as we go along. We'll be able to answer those, and the chat should be enabled. All right. So Nina Schwalb is here. She began her career in public health over 25 years ago in a refugee camp in northern Thailand. Currently, she leads a public health advisory service that provides policy and strategy guidance to governments, international organizations, and foundations. Before that, she was the Associate Director of the Program Division and Chief for Health of UNICEF. She also served on the executive team of Gavi, the Vaccine Alliance, and directed the policy department at the Global Alliance for Tuberculosis Drug Development. There she focused on product introduction and advocacy. She has worked across Asia, Europe, and Africa. I found Nina because I heard her speak on this work previously in the past, and I thought, we need her to work now in New York City. Apply that skill set here, and I'm so glad that she is doing that with us. And we also have Dr. Stanley Pierre. He is the Patient Safety Coordinator and Director of Clinical Centers of Excellent Development Program at NYC Health and Hospital Queens. His areas of expertise extend across multiple settings throughout the healthcare spectrum. He has extensive experience in hospital and clinical operations, analytics and population health management, quality, patient safety, patient experience, emergency management. He aims to build, maintain, and sustain clinical, operational, financial solutions across systematic processes that can be replicated. He also comes with a medical degree in Haiti, a master's degree in public administration from NYU Robert Wagner School, Graduate School of Public Service, and also has experience in vaccination programs in Haiti, and he's drawing on all of that to help us with our program around healthcare workers and vaccine confidence now in New York City. And Dr. Janine Knudsen is a primary care doc at Bellevue Hospital. She provides team care to immigrants, refugees, and people with housing insecurity and homelessness. She's also right now the medical director on the special operations team for the New York City Department of Health and Mental Hygiene at the Office of the Commissioner. Before that, she was the medical director at the NYC H&H Office of Ambulatory Care and Population Health. She has an MD from Harvard and a BA from public health studies from the Johns Hopkins University. So glad that you all can be here today with us. Thanks so much for taking the time. I could talk forever and listen forever about vaccines, about vaccine confidence. I often do it alone. I'm so happy to do it virtually here with all of you and with our audience today. So really looking forward to our conversation. Dr. Knudsen, I'm going to start it off with you. Yep. I know that the health department has been really busy, really actively thinking about how to engage the public around vaccine confidence. They've done this before the COVID-19 vaccine existed, right? We've done this with other vaccines. And so could you talk a little bit about that process at the health department and how that's going?
Definitely. And I will say I'm here to represent the decades of work and the incredible work of the whole organization. I think it really runs deep at the health department to do this kind of work, building confidence in vaccines, but also healthcare in general. So I'll do my best to summarize it. I think most important are the principles, which are that we recognize at the health department that vaccine confidence goes hand in hand with health equity. The concerns, the reasons that people in the community may have low vaccine confidence often have so much to do with health equity, with structural racism, with histories of trauma. And recognizing that is so important because otherwise we are placing blame on people in the community that they are the reason they don't feel confident in the vaccine. So I think it's really, really important to recognize that foundational concept, and that really underlies a lot of the work that we do. The other most important element is relationships. I think so much of the vaccine confidence work is relationship driven. At the health department, that means it's all about working with our community partners and developing the relationships with them, but then also finding the community partners that really have strong relationships and trust in the community. Whether that's a neighborhood community, a population group, or a healthcare workforce community. It's all about relationships at the end of the day. And people, we've just seen over and over again in presentations and meetings that people feel most comfortable getting information from people they know and trust. And so we have done everything we can to build up an infrastructure to pass on the necessary information to the trusted messengers, trusted members of the community, so that they can pass that work on. So those are the foundational principles. I think without going into the details, I'll just say that there have been hundreds, if not thousands, of meetings and presentations so far to engage people that can do this work with us, in partnership with us. And that we'll continue doing that until this vaccination campaign and this pandemic are over. I think we recognize that it's very long-term work. It will take an intense amount of effort and time, but that it's worthwhile and that that's what's needed to really build up confidence in the community. I'll stop there, Kristen. We can hand it off to other folks. Oh, you're still muted, Kristen.
Of course I am. Am I unmuted now?
No, you're great, thanks.
I joked that I have an 18-month-old. His first full sentence is going to be, "You're on mute." Sorry, so as a follow-up, I just wanted to ask you, and specifically, I know a group of us are interested in the role of healthcare workers and community health workers, and you work a lot with community health workers. What do you think their role can be in addressing?
Yeah, no, thanks for highlighting that. I think they're such an interesting workforce because they're right at the intersection of the healthcare system and of the community. And so they really are able to bridge those two worlds, and therefore are a really essential group of trusted messengers that we need to engage. I think that we, in the community partners that the health department is working with, many of them have community health workers or are training up their workforce to become community health workers that can help people navigate the very difficult vaccination sign-up system, help them navigate all the information that they're getting flooded with, and really get out into the community and spread the message that the vaccine is a positive thing. That's both a factual message and an emotional message. And I think community health workers are really good at bringing both the factual and the emotional to their work with clients and with the community. So, but to get concrete, I think what this means for the health department is really finding the right partners that have a community health worker workforce and engaging them and hearing their feedback and working with them to get them the information they need to do the work that they need. So there are large collaboratives of CHW groups. There are large collaboratives of community partners who may have CHWs as part of their workforce. And we're engaging with all of them to try to get the message out, and again, to receive the feedback so that it's a constant iterative process with them to make sure they are able to address vaccine confidence.
Thanks. Dr. Pierre, I want to shift over to you for two reasons. One, because you're doing so much work at Queens with healthcare workers right now, and also because of your experience in Haiti around vaccine confidence and with community health workers as well. Do you want to just first tell us a little bit about what you guys are doing at Queens for vaccine confidence in the healthcare workers?
Of course, Kristen, and thank you for the wonderful words earlier. And it is a pleasure and an honor to be here talking about vaccine confidence. So at Queens, we really had a very specific approach to vaccine confidence. Our leadership team has gone around and made some rounds going to the units and really talking to the staff members, asking them questions and answering their questions. And also we're able to disseminate some vaccine information to our staff members via emails. And also we had some one-on-ones conversations with staff members. And we quickly realized that the best way to really fight misinformation is with the truth. So we'll honestly answer their questions and provide them with the information that they are asking for. And when we know the answers, we will answer them. But if we don't know, we'll actually circle back later with them once that information becomes available. But first and foremost, we made it easy for the staff to receive the vaccine. And that was key, in fact, that is key, in fact, actually to our success.
Can you talk a little
Easy
bit more?
for them, yes, easy for them actually to register. We allowed walk-ins when possible. We practice staggered staffing on the units, allowing staff to rotate so there is coverage and they can receive actually the vaccine. The vaccination area is highly visible. You cannot miss it. We had town hall meetings, and really we also had crafted messages, making sure that people don't understand that, you know what, this is the disease, but we know so far actually about the virus, its complications, and the vaccine. Really, do you want to take your chances with either the vaccine or the virus? Helping people make that decision. And really, we made it visible for them to know who among our leaders received the vaccine, and that way they can ask questions, and also we could also provide them with information.
Thanks. I think it's such an important point even to raise here when we're talking predominantly about vaccine confidence, this issue of access, right? Because even people who are very confident or who are, sort of on the edge about whether or not to get the vaccine, if it's not easy for them to get it, they're not going to. And I think it's so key. I'm really glad that you raised that. And it's true just for healthcare workers as it is for the public. So that's great. One question I said, you talk about having one-on-one conversations. Who's having those conversations? Who's the we? Is it you? Is it just you walking around talking to everybody at Queens, or is there a group of you?
No, I know actually not at all. We are having it's a team approach. Different leaders, different expertise, really being truthful actually with the staff, asking them questions, and also answering these questions. Our CEO, COO, CMO, CNO, the different directors, myself, we are asking staff questions whenever we see them. And in fact, and we ask them also for feedback. Well, what are your issues? What are your concerns? Ask me any questions that you have. I will be truthful and I will answer your questions to the best of my ability. And really, it's having that level of conversation, actually with staff members.
And how did you figure out who those trusted leaders were going to be, and the trusted people within the healthcare communities as well?
Actually, for us, our leadership team just step up to the plate, because like Dr. Masci mentioned earlier, Queens was the epicenter actually of the virus here in Queens, actually in New York earlier last year. So we've experienced firsthand what that disease can do, how deadly it can be. So that really was, I'll say, the driver being our leaders just doing what needs to be done. Because in the end, we have to get our hands around the virus. We have to be able to control that disease. We've lost way too many lives.
Thanks. I want to shift a little bit now to your expertise in doing vaccine work in Haiti. And I know it's a different environment, but what lessons learned there do you think we can bring to the process here in New York City?
Kristen, I can really think of a few things that we can do here. First, for any vaccination program campaign to be successful, access has to be at the forefront. And that's one factor. The other pillar is also, well, being able to leverage our leaders and also our community workers. And the fourth pillar is education. Education is education. And For access, for instance, I can take actually up a few things. It's being able to have vaccination centers here to the city. But we can also have, but to take off vaccination centers, two things come to mind. We can build big centers or smaller centers, because the idea of access is going to the community, is making that vaccine available for actually for our community members actually to receive it. It is really important to remove barriers in a sense that, well, we need to look at our schedule. Do we go 7 to 7, 9 to 5? Or what about extending the hours to have a 24-hour coverage? Since people in New York work different shifts, make it convenient actually for people. It is a great plan to reactivate doctors and nurses, because now we need people to administer the vaccines. But in fact, there's also a large contingency of doctors, of foreign grad doctors and nurses that really can administer the vaccine. So how do we leverage our policies to allow them to bring their expertise by using their services actually for the vaccine? We also have home health nurses and hospice nurses who go in people's house to also see those patients. Can we use them to also administer the vaccine? That will require for us to probably to have for the vaccine, but these nurses, they go all the time to people's house. So why can we use them to really administer the vaccine to family members? Since home health, actually their reimbursement is really around the margins, is based on time and their codes. Maybe change reimbursement system or reimburse them for that service, so they don't lose revenues. And also, inventory is key. Starting and stopping is not really helping us. It's not really helping the cause, because people lose faith. They lose confidence, and being able to streamline actually the process for registration. Now, we have leaders. We have elected leaders actually among us, but we also have that concept, both formal and informal leaders. Formal leaders actually are known. They are our officials, they are deans, school principals, clergy members, and all that. But what about the informal ones? Those are our barbers, our beauticians. Those informal leaders, they play a key role. The bodega owners, the neighborhood stores. People go there, they spend time there, they ask questions. So we can educate them on the vaccine, provide them with printed materials, give them the education, and use them actually as a tool to really encourage our community members to receive the vaccine. Hold sessions with them to educate them. And with that, we can really speed up actually the number of people that can truly be vaccinated. So our healthcare workers, they are key to success, because they already know the people. They are embedded in the community. But also, when I go back to home health and hospice, there is a group called private duty services staff members. Those are our PCAs. They also go around and see patients. But we can give them the education so they can really be able to hold that conversation and be able to start it and get people involved, get people interested in getting actually the vaccine. So I think there are a few things that can be done, but I'll just name those and send it over to you, Kristen.
We have a lot to work with there. Thank you, Dr. Pierre. I think the two things that really hit home for me too are this idea that access and problems with access can drive issues around confidence too, and how those are really related. And really thinking about this key informal leaders, and it ties back to Dr. Knutson's point about the importance of relationships, right, and the relationships that exist in these communities already with that group. Thank you so much. Nina, we're going to bring it over to you now. Similarly, you have a lot of experience around this with Gavi leading their strategy around vaccination. What do you think can be improved in our vaccine confidence work? We'll start just here in New York City, and then we can sort of move more broadly and globally. And you're muted. It's not just me.
Sorry, kids in the back too. Thanks again for inviting me. I'm really excited to be engaged. As my friend said, though, I wish I were not in the experimental arm of this of this grand global experiment. But I did actually want to step back a bit and reflect. I mean, there are three things that are really important to me. The first is that vaccine hesitancy is not new. The second is that it's a global phenomenon, and the third is there's things we can do about it. You know, many of which were just mentioned. So I just want to start with it's not new. I mean, in the 19th century, there was a huge movement, anti-vaccine movement around smallpox. There in 1879, there was something called the Anti-Vaccination Society of America. And even in New York City, we had our own Anti-Vaccination League of New York City in 1885. And then, you know, this following an outbreak in Massachusetts, somebody where they mandated vaccination, a resident sued and it made its way to the Supreme Court. And thankfully that led to public health laws, which empowered our states to have a little bit more muscle. So this is not new. We've been dealing with this for a century and a half, since really the very beginning of vaccines. I mean, the second is that vaccine hesitancy is global, and it's not unique, sadly, to New York or to the US. In 2019, the World Health Organization listed vaccine hesitancy as one of the top 10 threats to global health. This was way before COVID. Wellcome Trust did a survey in 2018 where they showed that there's about 80% trust in vaccines. I mean, that's, Kristen, to your, that's the glass half full, but there's 20% lack of trust or distrust or hesitancy. And that really ranges by region. Some regions are very confident, South Asia, others, Eastern Europe, considerably less. And I would say that the global community has done a lot to mess with that in a way. And I think one of the great examples is polio in Pakistan. And I think when we read the news that the CIA had actually found Osama bin Laden, you know, that was exciting for many people. For the public health and vaccine community, when we learned that the CIA had been disguised as vaccinators to get to his house, that really didn't say much for what that action was going to do around building vaccine confidence. You know, and I think what you've mentioned already, you know, the determinants of hesitancy or lack of confidence are the same around the world: attitudes, past experience, trust, social norms and standards, and sort of your worldview. Just want to say, and you know, the digital, we can't sort of in this issue ignore the sort of the perspective on the digital age. And there was a great article in the Lancet earlier this year, which talked, you know, about the fact that these face groups, there are 31 million people who follow anti-vaccine groups on Facebook, similar numbers on YouTube. It's a huge industry, revenue building industry for these social media platforms, and that there are ways that these clusters intermingle between sort of the anti-vax intermingling with the undecided. And that's actually quite similar to what happened in the 2016 elections when the Russians interfered, you know, with the undecided voters. And it's a similar push around the anti-vaccine movement. So that again is to say it's global, it's more than New York. And I think we have to put ourselves in that context. And then the third point I want to make is that I really believe this is eminently solvable. And I think we have evidence to show that that's true. And I read a report recently which distinguished between disinformation and misinformation. You know, and the disinformation is much more sort of nefarious, monetized, polarized, politicized. And there was an example I read about in Pakistan, which was a video of a little boy getting sick after polio vaccine. And within 24 hours of posting that vaccine, it had 24,000 impressions on Twitter. And that was active disinformation. And I think on the solution side, I think organizations like Gavi, the Vaccine Alliance, and the World Health Organization have been working with big tech to try to get that stuff off the big tech platforms and convince big tech that they have an important role to play on that. And then there's another effort which I find extremely heartening in the age of misinformation, is to actually work with youth around digital literacy and literacy around health information. And there, again, there's, for those of you kind of who love to read, there's a great article in Frontiers in Public Health around some of these efforts around inoculation of youth by teaching them around what is a trusted source of health information. And then there's the misinformation. And this is, again, where I'm endlessly hopeful, because New York is so strong on community-based organizations, and we have such good networks, and we have community health centers, and we have rosters of voters, and I have a block association, I have a building association. I mean, we have trusted leadership. And there was a report, again, by WHO, by this group called the SAGE, which kind of guides all things vaccines for the World Health Organization. And it was done in 2014, which arguably was before kind of the big tech, although it had started then. I think it's now just gone on crack, but it was before that sort of massive influx. But it says, focus on the unvaccinated or under-vaccinated. It was, you've talked about improved convenience and access to vaccination, work closely with local communities and healthcare workers, and engage leaders. And to that point, I just I'll come to an end here. I think that point about leaders is really important. I think too often when our leadership hears engage leaders, they think the head of the hospital, the mayor, the whatever, those are not necessarily the trusted leaders. And it really is the local community leaders. And I struggle to understand how we get that message across, that the leader can be, as you said, the pharmacist, the bakery owner. It's the people in our neighborhood, not necessarily. But I did want to give one example from Gavi, actually from my time at UNICEF, of where we engaged leadership. In Kenya, in 2014, we had a big problem with the bishops' conference, of the Catholic bishops' conference, and they were, convinced for whatever reasons. It was a political battle that was happening at the time with two political parties, and they made a big statement which took tetanus vaccine off the roster of essential vaccines, because they said it was a sterilizing tool to sterilize women. And this was for a maternal tetanus program. As you all know, maternal vaccination programs can be tricky for exactly that reason. So the Catholic Bishops' Conference said we shouldn't be offering this vaccine. It was actually taken off the offering of vaccines. That we thought, well, what's the leadership that's going to influence this group? The Pope. So we went to the Pope and we said, we have this little problem. We took a little while, it was a couple phone calls to get to the Pope, but we got to the Pope, and, and he intervened. And that was great, because he got tetanus vaccine back in the roster of vaccines, but our work didn't stop there. I mean, to this day, there's distrust of that vaccine, there's distrust of vaccine. So that's one part of the story, but it doesn't obviate that really working day to day with the local people that people trust. So I'm super excited that New York City has put that forward. I've been working with a community leader here, and we've applied to be one of those centers on the Lower East Side, and we found our 5,000 square foot space, and we're excited to really dive into this. So thanks.
Thank you. Thanks so much. I mean, thank you for bringing up the whole misinformation, disinformation, right? This big infodemic is a huge part of this problem. It makes me feel really good that you think it's solvable. So I'm even more positive after that. I think we should, if we have time, touch on some more solutions for that as well. I think one thing that you raised, and Dr. Knudsen pointed out earlier too, is this issue around systemic racism and how that affects vaccine confidence. And for me, in health equity, and how do we tie these two things together? How do we have both conversations at once? Or should we not be having both conversations at once? Should we really keeping them separate? I'd love to hear what the health department's doing in that, and also just what you guys think about how do you say, yes, there are terrible injustices that have happened historically and currently, but we still need to move forward with the vaccination campaign. And I'm struggling with that, both in my clinical roles as well as thinking about other work that we're doing. So do you want to take that first?
Thanks for bringing it up. I know, and I think I'm going to try to channel all the experts at the health department who are really getting on the ground and having these conversations. Do my best to explain how their work. I think that the most important thing is to not shy away from talking about those two issues together. There's definitely a concern that if you gloss over the reasons why people may have vaccine hesitancy, if you gloss over their concerns and their history of institutions mistreating them or mistreating people like them, I think you lose people in that. So it is really important actually to not divorce those two concepts. I do think though that there is there's a way to link them together and not just reinforce the concerns that people have related to systemic racism and institutional manipulation, basically. And I really think that the answer for that is through storytelling. So what I mean by that is that if we can address the systemic racism and the concerns that people have, but then share a narrative about the vaccine that's all about putting control back into the hands of the community, back into communities of color, and back into communities that have been most affected by COVID, that can really help. And so stories that share how getting the vaccine empowered people to finally confront the pandemic and get their lives back. Stories about why they're taking the vaccine to protect their family or to protect their neighbors or their patients if they're healthcare workers. And I think that will really help because at the end of the day, it's really an emotional discussion and an emotional argument, and more facts about why people should trust institutions and why the vaccine was created in a safe way are not really going to win over people's hearts and minds. I hope that was specific enough, Kristen. I'm happy to go into more detail, but I think generally keeping those two themes linked and focusing on people's stories and stories from the community, not from the health department, are really going to overcome some of the concerns.
Thank you. No, that is helpful. I think the idea of being able to continue to link those is one I wanted to hear. Please, if anybody has references that they want to put into the chat box on organizations that are doing this particularly well. Also, I'd encourage anyone out there listening to put any questions you have in the chat box as well. I have lots more questions of my own, so this can just be my time to ask questions, but it's really not supposed to be for that. It's supposed to be for everybody. So feel free to put those to us. Dr. Pierre, do you have any additional comments about how to address the issue around racism?
Actually, in fact, that question was raised by a few staff members to me directly, and in fact, actually, I did, like Jenny mentioned, brushing away actually the issue is not the solution, and really it's having that conversation. And in fact, which means that understanding where they're coming from and point out to what makes this time different. And sometimes it works, sometimes it doesn't. But it's really being able to share the story about the vaccine. But for us also, we have also our leaders who are people of color who also do the vaccine. And turning around and say, you know what, guess what? Dr. So-and-so got the vaccine. Nurse so-and-so got the vaccine. Well, she had both doses. So what did you ask her? And maybe that person might be able to share its own experience with you. And that would help you make an informed decision. And that's how actually I was able to approach this actually with our staff members.
Thank you. That's a great example. I appreciate that. I'm also trying to read the text box. Sorry. So there's a question here about vaccine distribution, and I think Dr. Knudsen will send that towards you. A concern that if vaccines being distributed predominantly to where it's being used up the fastest, is that what is the impact that that's going to have on communities of color and eventually disproportionately affecting their ability to access the vaccine?
It's such an important question. I think, if we build up vaccine confidence and then at the end of the day, someone still can't get a vaccine appointment, we really lose all the momentum and we lose trust and we really contribute to people's lack of confidence in healthcare systems. So it's so important to provide access. This topic of ensuring that communities of color, communities that have been affected by structural racism and by the pandemic have access to the vaccine is the top priority of the health department. So there are a lot of different strategies we have deployed and hope to continue to deploy to make sure that there's continue to improve access to vaccine. Sorry, it's a work in progress. So I'm just trying to use words that describe how I think it will continue to get better and better with time. One of the specific examples I can share, or there's two, I think, we know that in many communities that are either low income or under-resourced or disenfranchised, the federally qualified health centers and the pharmacies, the private pharmacies in those communities are really important points of healthcare access for people. And so we're doing everything we can to support those smaller healthcare organizations to have vaccine and be able to share it with the community. just to make sure that the vaccine isn't going to all the large chain pharmacies and the large hospitals, et cetera. So that's an important piece. I know a second one is to make sure that all the public locations where we have vaccine, where we're deploying vaccines, so the city pods or the state pods, that they're in areas of the city where people live that we're trying to reach. That doesn't always mean that the appointments are available for those people, but that I think is something that will improve over time. And then the final piece is just bringing the vaccine to areas where we know there's high need and where we are concerned that there may otherwise not be access. And the best example for that is NYCHA housing. So there are some really exciting pop-up events or vaccine clinics that have been started in NYCHA housing to offer vaccine to people who live there. Many of them are healthcare workers, which I find so interesting. Many are medically frail or medically homebound. Many of them are, city essential workers. And so it's perfect. It's the synergy of all of our strategies. Getting to bring vaccine to NYCHA, I think is a great example of that. I hope that was a good enough answer. Again, work in progress. And it's really helpful to get feedback from people in the community to keep us honest about who's getting access to the vaccine and who's not. So we really want to keep those channels open for community feedback to make sure that we're really being equitable in our distribution.
Thank you. No, that was a great detailed answer. And just to thank everyone that you're working with for all the work that I know is happening 24/7 behind the scenes. It makes me proud to have such a great health department that I know care about these issues and are addressing them. I think we have time for one last question before we wrap it up. And that is the idea of that a lot of the trusted messengers that we've talked about that we want to use in these informal leaders, they're not necessarily on social media, right, where all of this information, disinformation is happening. And so how can we connect this idea of taking all of the misinformation, aggregating and synthesizing it that the companies are working on out there with getting that work to the real world work that's happening by these trusted messengers? I don't know who wants to tackle that, Nina.
I'd like to, I mentioned that that we signed up to be one of these community distribution sites, and I think I really think good old word of mouth in New York is really important, and people do have networks. We talked about democratic voter registration. We can get out the vote really easily in New York. We have incredible, we can find every Democrat on the planet in New York City and call them, and we actually even know their age on those rosters. So I think just going back to word of mouth, community and local networks, I just can't, we're lucky to live in a city. We're densely populated, which hasn't been so great for COVID, but we do interact with one another. I think we become overly reliant on social media and forget that there is such a thing as talking.
Nina, I think that's a great example. And in addition to get out the vote, I think the recent census effort is another great example of how a community organizing approach was used to get out the word about the census and build confidence and trust in a government effort. And the way that was done is that community groups were contracted to do that work. They both did the in-person tabling, et cetera, but they also created their own social media content, which I think is so interesting, like their own videos, their own tweets and Instagram posts and memes that were spread. And I think that is a strategy that will be really helpful here. I do want to highlight, I'll try to maybe put it in the chat, that there is a really excellent national organization that's been talked about a lot called the Public Goods Project. The reason that I bring them up is that they do very regular scans of social media to understand what misinformation, what themes are coming out there. And they've done pilot projects to actually pay social media influencers to post content that debunks some of the myths. So there are just a lot of exciting strategies out there that I think are going to become used more and more. Oh, great. Amanda put it in the chat. That are going to be used more and more, and I think are going to go hand in hand with the in-person strategy.
And also, actually, in fact, to piggyback on what Nina and Janine actually were saying, old-fashioned posters, plus we live in New York City. The buses plaster actually some of the community leaders' face on those buses, encouraging people to go ahead and be vaccinated. And billboards, using the billboards also to be able to reach out to the community. And those are all strategies actually that we can use to really get the word out.
True.
I'm sorry, I just wanted to just go back on the systemic racism. I mean, I do think that's really the underlying problem with this. I mean, it's not the vulnerabilities that people have that make them vulnerable to severe COVID are tied to systemic racism and lack of access to healthcare. And I'm just terribly disappointed that that isn't more of the conversation at city, state, and federal level, that the underlying problem in America is that we don't have access. Vulnerable populations, those who have been victims of systemic racism, do not have access to primary care and hence have diabetes, hypertension, and heart disease. And I just wish that was also part of the messaging in the billboards is, while you're getting your vaccine, why don't you check out your primary health care? We still have 4 days to sign up for Obamacare. Let's get that out with the message. So that's one thing I'd really like to see moving forward.
It's a great point, not losing this opportunity and focus just on one issue, and hopefully when this goes away, everything else unfortunately stays, and it's worse.
Yeah, I think, and sorry, Kristen, I know you're trying to wrap us up. We have a lot to say. Part of that to me is really about crafting the narrative that this is a positive resiliency moment to get the vaccine. I think right now, like as we all know, the vaccine is wrapped up in a lot of anxiety and concern about safety and access and all the misinformation. There's not a lot, like the narrative really hasn't become that positive yet because of all the problems. Once it becomes a positive narrative about getting your health back, getting your community back, doing what you can for others, and having resiliency during this pandemic, I think that will really help. And then you can add additional agenda items to that, like getting health insurance, getting access to care, getting good housing, access to food, you know, all the social determinants. That could sort of go into it, so it's not just about the vaccine. And hopefully that will come.
Great, thanks. Unfortunately, we're going to have to start to close this out. I could do this forever, but we'll do the lightning round right now. Everybody has about 10 seconds, but my glass is half full. I want to hear one thing that we're doing well and one thing that we could improve. All right, Dr. Knudsen, I'm going to go first with you.
No pressure. One thing that we're doing well, I think I'm a broken record now with community engagement, but I'm really proud of the work that the health department has done to find community leaders and community partners, many that we already work with and many new ones, and to really keep the conversation going with them. So it's not just a one-way flow of information, but we're truly partnering with them to get the word out and understand the concerns from the community. I think what I would change is I'm excited about this positive narrative that eventually the vaccine is going to be seen as a celebratory thing in the way that it already is in small ways, but that sort of narrative hasn't trickled out to the broader community as much yet. And I think that will change, but it's going to take some work. So excited to see that happen.
Thank you. Dr. Pierre.
Well, one thing that we're doing well is really engaging the community, is getting that conversation started and getting people actually to be excited actually about the vaccine. And one thing actually that I would probably change is making it really easier for people to be able to register for the vaccine. Not everybody has access to internet, or we also have older folks among us who will use the internet. So make it easier for those people to receive the vaccine.
Thank you. Nina.
One thing that I think we're doing well is not yet using the National Guard. I think this is a really bad idea. Portland, Kent State, like not building trust. I'm going to leave it at that. I think we're doing that really well, and we should continue to do that really well.
All right. I want to thank all three of you for participating today. This has been great for me. I think my takeaways really are not to forget about access when we think about vaccine confidence. This is a long game, right? This is not, we don't have short-term solutions to this problem. We're really going to think about it in a long term. Not separating health equity, structural racism from the issue, and also not separating everything else that has to do with that in terms of disparities in healthcare when we do that as well. This importance of storytelling and using informal leaders to help us through the way. And thank you all so much. I appreciate everybody else who attended and listened today. I wish I could see you, but someday again we'll be able to do this in person if we do our jobs well, right? Please, there'll be a webinar recording 24 hours or so on YouTube. that we'll hopefully send out the link to. Everybody can listen to this again or share it with friends who didn't have a chance to make it. Really appreciate everybody taking their time today, and have a great week and stay well.